So in spite of the values, the funding has not really followed what the values are. They just haven't been in sync. Child welfare systems are funded through 3 dedicated federal funding sources, other federal programs that are available for a wide range of services, and then state and local funds. The federal law dedicated to child welfare is Title IV-E, Title IV-B, and the Child Abuse and Prevention and Treatment Act. And of the 3 of those, Title IV-E is it's just massively bigger than any of the others. So states, in fact, use the other programs to fund child welfare, but they mix and match what makes sense for them. But so 4E is the most important federal funding source for child welfare. Next slide. In fact, it represents 55% of federal expenditures. But of course, as you are aware, it's focused on foster care itself. So what it does reimburse is it reimburses a portion of the cost of case planning, placement costs, placement resource development, training, and administrative costs related to those. But it doesn't pay for a lot of things or reimburse a lot of things as well. Next slide. It does not reimburse for the cost of investigating abuse and neglect reports. And until Family First, it did not reimburse states for the cost of services to prevent placement, in spite of the fact that it was required in the law. So most of the reimbursement was triggered only when a child was removed from the home and put into out-of-home care. So 4E does not pay for the cost of services, social or clinical, but it does pay for case planning, case management, case supervision, and oversight. And in 4E law, those are not considered services. They're considered administrative expenses. And 4E does reimburse a portion of the cost for administration. Next slide. So since 4E was enacted in 1980, advocates and states have been so frustrated by the limitations. You're required to prevent placement when you can, but yet there's no real federal funding to do that. So the concerns have been around lack of flexibility, incentives, accountability, etc. The proposed solutions have gone the gamut: block grants, waivers, expanded entitlement incentives. And what was selected by Congress was to allow for 4E waivers. In 1995, states were allowed the opportunity to apply for a waiver of federal law in 5-year demonstration projects. Next slide. But for the most part, the waivers were not used to provide services that were not allowed in the law in the first place. In fact, if you look at this chart, which is from a report that was done recently, completed recently, most of the states spent most of the money on services that could have been purchased without the waiver. And only 10% of the funds were for services that were not allowable under 4E. So they were spending most of the money on things they could have done anyway. In Maine, you had 2 waivers. One was for adoption services, which included post-adoption support services, clinical services, and parent education and services for caregivers with substance use disorders. Both of Maine's were actually waivers that were paying for services that were not allowed under 4E. But you were not in the majority, you were in the minority. You actually fulfilled what the goal of the waiver was, but very few states did. Next slide. When you look across all the states, about half the states applied for a waiver. When you look across all the states, you can look and see how money is spent. Only about 15% is spent on preventive services out of all the money spent in child welfare. And a lot of that is spent for hard services like rent deposits and refrigerators and things like that. And very few states were able to actually capture or discuss how much of the money they were spending on evidence-based practices. Next slide. And many states were spending a lot of money for group placements. And a lot of the money was spent for kids without clinical needs. If you look at this chart, and this is 2016, and it's changed a little bit in subsequent to that, but if the variation of the percentage of kids in group care is huge. It's from about 5% to almost 25%. And when the congressional leaders looked at that, they said, how can it possibly be that kids in some states have so much more dysfunction that they need mental health residential treatment than in other states? Well, because they realized that group care is often used just because there aren't enough foster families. Maine, of course, is in the top 10 for doing a good job at limiting residential placements. But there's a lot of states that were not doing very well. So that was concerning to congressional staff. Next slide. And if you look at kids 13 and older, who are the primary target for residential placements, again, you see a huge variation. And Maine, again, is in the top, third in the country in terms of the percentage of older youth in group placements. In fact, because of Maine's good practices in that regard, that was sort of a role model for congressional staff when they started thinking about what needs to be changed. And the thing about group care, as you know, is it's so much more expensive than providing services to intact families, or even services to children in foster families. Next slide. So the backdrop then on Family First was that there was limited spending on preventing placements and too much spending on residential care. And if you look at the percentage of, or the number of states spending money for behavioral health services through their child welfare budgets, you can see that there's probably 17 states, not even half, are spending child welfare dollars for those services. Yet, there's a lot of complaints about the availability of substance abuse and mental health treatment services. Next slide. So, they had reached, congressional staff and leaders had reached several conclusions. One, that states were overusing group placements, and many of the group programs didn't even have a real clinical model or clinical staff. Few states were providing clinical services to prevent placements and support families. Few states were focusing their preventive services on services with an evidence base, nor were they evaluating the effectiveness of the services that they did purchase. Few states were measuring the impact of preventive services on family stability or the need for placement. In other words, if we're giving you this service to prevent placement, if you look at it over time, did it actually succeed in preventing a placement? And finally, few states were supporting kin caregivers or had up-to-date, really current foster family certification standards. So this is where what they concluded after their analysis of what's been going on in child welfare. Next slide. So their solution is the Family First Prevention Services Act. It provides substantial changes to federal financing, new resources for preventive services, and restrictions on reimbursement for group care. It captures a lot of data on what the practice weaknesses have been. It addresses concerns that FORI reimbursed for placements, but not for preventive services. And the reason they were able to get enacted in 2018 was that when they sent this whole package to the Congressional Budget Office, the Congressional Budget Office was able to say, we believe that by reducing the use of group care, we will have enough money to fund an unlimited pot for preventive services. And so that's how it came to be, was it was considered cost neutral. And the inappropriate use of group care would be addressed through this qualified residential treatment program set of rules that has also been included in the law. Next slide. So now let's talk about what the basic definitions are and requirements for the preventive services program that's now allowed through 4E. Next slide. So the primary focus is to prevent foster care and limit and improve residential care. So that means investing in prevention through family-based services provided to the child, the parents, or kin caregivers. It's not just limited to services for children. To ensure the necessity of a placement that's not family-based, ensuring the quality of residential treatment, There were some modifications made to the Chafee Foster Care Independence Program, however, no additional funding for that. And a lot of new state reporting and data collection requirements, which are somewhat burdensome, and I'll talk about some of them. Next slide. So the biggest opportunity, I think, is an open-ended federal reimbursement for services to prevent entry into foster care for all children at risk of foster care without eligibility requirements. That means there is no income eligibility requirement for these services, which there always has been as a part of Title IV-E. All children at risk of foster care are eligible for this preventive services program. There's also an opportunity to beef up kin and foster family resources and opportunity, which is a lot of restrictions on the use of group placements. Next slide. Part of the limitation, however, for this program is how at risk of foster care is defined. So it's a risk of foster care means you are a candidate for foster care. And this has been defined in federal appeals court cases so that it's pretty much set in stone. A candidate is a child who is at serious risk of removal from the home as evidenced by the state agency, the child welfare agency, either pursuing his or her removal from the home or making reasonable efforts to prevent such removal. Now, the second bullet is just as important. A child cannot be considered a candidate when the state agency has no formal involvement with the child or simply because they're in an at-risk situation. And there has to be some documentation of risk, either the case plan that identifies that foster care is the goal absent preventive services, an eligibility form used for 4E, or some kind of a court proceeding related to the child's removal from the home. So that's the front door, basically. You have to pass that standard in order to get access. But interestingly, the candidate also specifically includes aftercare, which is another really great opportunity. A child who is reunified after they've been in foster care, or a child who's adopted or placed with a relative can also be considered a candidate. We all know that kids can bounce in and out of foster care after they've been reunited, or if they're in an adoptive placement. So any child who returns home or returns to family, adoptive kin or birth, can be considered a candidate for preventive services. So that's a great opportunity. The length of time that a child can be considered a candidate is not really specified. However, the state has to re-justify the candidacy every 6 months. And a preventive service episode can be up to 12 months, but you can authorize additional episodes after that. So this is really wide open in terms of availability, as long as the child meets the bar initially as being a candidate. Next slide. So the general process then is that the candidacy is the front door. Both the criteria for who's allowed into this group and the process for making the determination of risk of candidacy or risk of placement have to be developed and approved by the feds in a plan that the state submits. And each state has to decide whether or not they're going to include populations other than the abuse neglect population, such as juvenile justice population, homeless youth, behavioral health kids. There are opportunities to include more kids as long as you meet those initial bars. And then how's the risk of determination or risk of placement going to be determined? Is it going to be done by a worker? Is it going to be done by supervisors? Is there going to be a specialized unit? All of those decisions, that process has to be created, and that's what one of the other work groups is working on. Since this is pretty wide open, I think what you'll see is a fairly significant federal audit of candidacy. So it's one of those items that you'll want to be really careful of in terms of creating the rules around it. Next slide. So what are the general principles of the program? Okay, it has to be provided in accordance with recognized principles of trauma-informed approach. In-home doesn't necessarily mean in the home of the child, but it means while the child is living at home. So it could be in a different location, but the child has to be living at home or with a relative. The needs of the child, parent, or caregiver must be directly related to safety, permanence, or well-being, or to preventing the child from entering foster care. And mental health and substance abuse services must be provided by a qualified clinician. But that's not necessarily mean licensed. It means the state will define who is a qualified clinician. So the state could define that as a licensed person or not, just as long as there are some qualifications established by the state. And then for each child, an individual prevention plan must be developed. Has to describe the foster care prevention strategy that will allow the child to remain at home or with the kin caregiver, and has to be developed in advance of providing the service. And for pregnant or parenting youth, the prevention plan must be included in the case plan, list the services, and describe the prevention strategy for any child born to the youth. Next slide. There's 5 categories of programs and services that are eligible: mental health, substance abuse treatment and prevention, in-home parent skill-based programs, kinship navigator programs, and residential parent-child substance abuse treatment programs. Now, the last one is a great opportunity. It's the opportunity to keep children with their parents while the parent is receiving substance abuse treatment. But it's only paying for the care of the children in that facility. It's not paying for the parental substance abuse treatment. Limitations, I already went over those. I think must be trauma-informed approach. Again, that's stressed in all of the written materials from the feds. Next slide. Now, what the feds have done, because of this problem of there being not that much money relative to foster care, but a lot of money spent on prevention services without particularly any evidence of success or any evaluation of whether they succeeded in preventing foster care. The feds have established a bar, basically a standard, by which all services that are to be provided through the prevention services program must be measured. They will have services categorized as either promising, supported, or well supported. And the judging of the evidence is going to be done by the 4E Prevention Services Clearinghouse. This clearinghouse was contracted out to Apt Associates, and they are basically reviewing all of the services that people want to provide to see if their standard of evidence meets the standards that they have established as promising, supported, or well supported. Now, this is another stiff bar. This means that you really have to have services that have gone through a fairly rigorous evaluation. Initially, the law required that 50% of the expenditures had to be for well-supported programs, which is the highest bar of the 3. That has been is now being phased in, so that it's by federal fiscal year 24 that 50% has to be, but they all have to meet one of these 3 levels. So the Prevention Clearinghouse has reviewed only 18 programs so far, and of those, only 7 meet the well-supported standard. Next slide. So the standards, I said, are being phased in. The 50% of expenditures will have to be for well-supported. The others can be for supported or promising, ultimately by October 1, 2023. And if they're not rated by the clearinghouse as having adequate evidence, then you can't really get reimbursement for them. And so basically the amount of service that you can claim is going to be dependent ultimately on how much you spend on the well-supported programs. If you spend $1 million on well-supported programs, it doesn't really matter how much you're spending on supported or promising, because the 50% has to be for the well-supported. Now that's by, as I said, October 1 of 2023. Next slide. So these are the services that have met one of those 3 bars. The top 7 are well supported, and those are, go forth and do good things. Those are all on the list. They've all achieved the highest bar. And then we have 1 in the supported category and 3 in the promising categories. Now, it's assumed that over time, some of these programs in the lower categories will have more evidence and can move up to well supported. But there's a number of programs that did not pass any of the levels. The next slide. These programs were all reviewed and were found not to currently meet the criteria, which again means that maybe they will eventually, maybe more evaluation data will be collected, or maybe the clearinghouse missed some data and the developers can submit additional data for it to be re-reviewed. The next slide. Then there are additional services. These 8 services are currently under review and may or may not make the cut. Now, a lot of time was spent sort of developing the process for determining promising, supported, and well supported. So I think you'll see the number of services being reviewed getting much faster in the future. So these are under review now. Some of these will clearly make it because there's a lot of evidence on them, but I think you'll start seeing them whipping through service categories much more quickly than they have in the past. Next slide. So the standards are rigorous. They're all laid out in a handbook that you can just Google and get that handbook. But they do require that the studies have to use either randomized or quasi-experimental group design. And they have to have intervention and comparison conditions with either randomized or non-randomized procedures. And the comparison groups can be used by a number of methodologies, but it can't be before and after. So they're tough. Frankly, I think that they got a little carried away with the standards. This is my personal opinion. The standards are a little higher than they should be, given that most of these services have never been tested on the child welfare population anyway. But c'est la vie. So go ahead. Next slide. So all of the services have to have written protocols, manuals, etc., that really clearly define what the service is, how to provide it, and that there may be training required for it. But what they're interested in is making sure that a service that does achieve the appropriate standards can be provided with fidelity, so that the service as it was tested and as it was evaluated is going to be the same service that's provided in each state that chooses to provide that service. Next slide. So each state will have to submit a 5-year prevention plan to get access to this funding. And in the plan, the state has to describe how the services were chosen and what the target populations are going to be. Service fidelity. So not only do you have to select services that have a fidelity measure to it and may have a developer who is going to achieve or measure your fidelity, but the state has to discuss how they are going to continuously monitor fidelity for service and how service effectiveness will be measured. So yes, you have to provide it with fidelity, but then the impact of that service, did it actually achieve the goals it was intended to achieve? That's also got to be measured by the state. And then importantly, how caseworkers are going to be trained and supported to understand what the services are useful for, who is the target population, how to identify the target population, and then to make sure the caseload size and type is meeting the kind of standard that it needs to meet in order to achieve the fidelity. And to make sure your workforce is competent and skilled to deliver the service in an evidence-based way. And then finally, service coordination, how the state agency and the community providers are going to be involved in ensuring a continuum. Now, this particular item is broad across service types, but it was really put in there because there was a sense that there was a very poor coordination between child welfare and substance use disorder service providers. So that is a particular focus. Next slide. So states are also required to take a number of really accountability types of activities. So the federal reimbursement is 50% until fiscal 26, and then it goes up to the same as the Medicaid percentage, which is about 63% in Maine. The state plan also has to describe how it's going to undertake periodic risk assessment for all these kids who are now living with family, and how the state will do continuous quality improvement and caseworker training. There is a maintenance of effort required. So if you had the service before 2014, you can't just shift that over to federal funding. The idea is that you're going to add funding, not just federally pay for services you're already providing. And the state has to include in their 5-year plan a well-designed and rigorous evaluation strategy for each service. So that's a pretty heavy lift as well. And there are a lot of performance measures that are going to be placed into, that they have to report on as well. Services provided, per child spending, duration. And then I think most importantly is these services are designed to prevent placement. So the feds want to know if after 12 months and after 2 years, did the child not have to get placed? It's reasonable, but not one that we've measured in the past. So it'll be interesting to see. I mean, it's going to depend on each state's information system, their capacity to actually collect that data. So again, the accountability requirements go on and on. Not only will the cost have to be for services meeting the standards, but there's going to be, again, lots of room for evaluators because the service effectiveness has to be evaluated, not for the array, but for each individual service. And for those of you who've worked with Medicaid, which has always been the payer of last resort, meaning if you have any service or any payer who will pay for the service, you have to use them first, and then Medicaid will pay if no one else is available. This law changes the rule to mean 4E is the payer of last resort, which means that if Medicaid can pay for the service, it has to pay first. And only for those children and families who are not Medicaid eligible or for services that aren't Medicaid allowable, then 4E would pay. Next slide. There is an opportunity to receive reimbursement for programs that have not been reviewed by the clearinghouse. There is a federal announcement that I've highlighted below in the footnote, that if a state feels that it has a service that can meet the criteria, it can get transitional payments if it completes basically a several-page form that lays out all the evidence. And if any other state submits evidence on a service and gets it approved, Maine could also provide that service. So I would look to states like New York, probably California, states that have may have a wider range of services and have a lot of internal capacity to develop all that data that would need to be submitted for a transitional payment. But basically, what this means is this is offering room for states to submit and get reimbursement for services that may not have been reviewed yet by the clearinghouse. Okay, next slide. Now, I want to just mention that Children's Bureau is very focused on youth and family voice and family-centered practice. And they're going to be looking at that, I think, very heavily in their auditing. So I just wanted to look at or have you see what the feds are expecting to see in terms of the services provided. There's a lot of ideas for what they'd like to see in terms of how an agency, either public or private, could include youth voice in their process. I keep looking down because my cat just ran in here and it's about to jump up on the computer. All right, next slide. So finally, just in providing some food for thought for you as you begin the planning process for what you're going to include in your service array, I've got some additional thoughts. Go ahead, next slide. So, well, there she is. I missed it. So much of what's contained in the law was designed by congressional staff to overcome what they saw as weaknesses in child welfare practice. Unfortunately, they are real policy wonks and don't have a lot of on-the-ground experience in terms of how things get implemented. So while the law is pretty detailed, there's still a lot of questions in terms of how's this really going to work. Next slide. And the bigger problem, I think, is they put into law a lot of what would ordinarily be in regulation. And that's, I think, a tendency in child welfare is they find one thing wrong and they just want to stick it in the law exactly. It's not a very clear way of doing it. So what I think is going to happen is what you see, what I've presented is mostly wording that's actually in the law. And you're not going to see any regulations, I suspect. The feds have put out some guidances, some policy ideas, but I don't think you're going to see any regulations. And I think that what is not clear right now will not really become clearer until it's approved in Maine's plan or it's approved in some other state's plan. So this is going to be a lot of iterations of states trying things out in their plans and seeing whether or not they get approved. And until you submit your plan, you really won't know whether your ideas will be approved or not. The feds have approved some funding to help states implement. Maine shares almost $2 million to help you think through what needs to occur in order to implement the law. Very little rules are around that $2 million. It's like a block grant, but obviously there will be a lot of demands on that from not only prevention services side, but there's a lot of infrastructure that'll have to be developed in the central office of the state. And of course, prevention service providers, how's that going to work? Okay, next slide. So I think that the question is, are there eligible services, prevention service that existed either before 2014 or fiscal year 14? And if those fall within the maintenance of effort, you really can't count them as prevention services, but anything after that could be. Because Maine has so few children in group placements, you're not going to obtain any big savings from reducing group care. You're probably already at pretty much the lowest level. And then a question around your providers. Are you currently able to provide any of the approved services in terms of already having been trained and having the skills and the materials, etc., or do you need to start from scratch? Or are there any other services that Maine providers are providing that may be on the list that the state's never purchased? So I think there's a lot of questions around what are you doing now? What could you do? What may be done at individual provider level that in fact could become a state prevention services service. Okay. All right, the state, as I said, has to provide this 5-year prevention plan. The interesting thing will be providing this data is, are the prevention services that we are purchasing achieving their goals in terms of costs, units? They want to really find out what works for this population, and this is the best way to do it. But it's kind of a heavy lift because you're going to have to keep track of all of these things. And as I said, I don't know Maine's information system, but there may be some modifications required to the information system in order to capture all of this data. Next slide. So in terms of planning, I think, need to take an overall look at what is needed versus what's currently reimbursable under Family First, and then think through how that list will grow so you don't limit yourself to a short list of 11 services. There's definitely going to be more by the time you're ready to implement. By the time you submit your plan at the end of this calendar year, I suspect there may be many more services approved. So it's going to be hard to sort of think through what services you want to provide. I would think about the services you're currently providing and what kinds of evidence there is to support those services and the ones that are likely to be reviewed. And the fact that they are letting us know which ones they are reviewing, I think, provide some help. For example, ABC program was on the list of services currently being provided. Well, there's longitudinal studies going over 8-10 years on that program, and I can't imagine it wouldn't be approved for well supported. So that's the kind of judgments you're going to have to make between now and the time you submit the plan, which leaves you with a fair amount of unknown, but you're just going to have to make some educated guesses. Next slide. So I think that while there's only those 11 services approved, you should be thinking about what you need based rather than what's fundable right now. Maine won't probably be implementing until closer to 2021, just because you're going to have to go through a process of submitting the plan, but then getting the plan approved, and that could take several iterations. Questions to ask, I think, what are the characteristics of the kids entering placement, so that you know what those reasons are why they're entering, which then you might be able to say, well, how could we prevent that particular issue from entering care? Who are the children with the worst outcomes? Who stays in care the longest? Who returns to care? Who are the bouncers? And who ends up disrupting placements? I mean, those are the kinds of kids that you want to see. Is there a service that could specifically address that particular need? Next slide. So, assuming that the state has matching funds, again, the federal government is paying a portion of, is reimbursing a portion of the cost, not paying the full cost. So it's 50% federal match now, eventually going up to the 63%. So whatever you decide to buy, you have to have the state match for. So you'll have to think about it in terms of what are your priorities for the kids who need the services. What are their needs? Are there evidence-based programs to meet those needs? And then are there programs or services that could address those needs within their families? Remember that you're also going to have to evaluate whether those services actually prevented placement up to 2 years after the fact. Next slide. So what are the considerations? They have to meet clearinghouse standards. The state may wish to purchase some homegrown services that have some evidence, but very few, if any, independent evaluations, because they meet a particular target group. They meet a particular population. You've got a Native American population. You could have an immigrant population where you have some services that appear to be good services, but in fact, you don't really have enough evidence on them. So these are all the things that you're going to have to be thinking about. Are there services that are so important to you as a state that even if they don't meet the standards, you feel the need to keep them in your service array? The important puzzle then will be defining the group of services that are most effective at reducing placements, and then prioritizing those within your resources, recognizing that many of the clinical services could be purchased through Medicaid first. Okay, next slide. One final note. I just want to add that I think that because of the rigorousness of the standards that you've seen, and if you look at the federal issuance that I've listed as a footnote, the standards are really tough. And it may be that in future years, there will be some effort on the part of the states to say, look, you know, these standards are too tough. They're too academic. And we need to have some lightening up. And I think it's worth thinking about for all of your services, whether they're going to meet the bar or not. You may want to begin to collect at least some limited data so that if those standards ever do loosen up, you've got a set of data that will allow you to at least speak to their effectiveness. As the federal government gets more attuned to these services, I think state governments are going to be requiring evaluation or effectiveness data on every service. And at some point, having a service without any data simply won't be good enough. And I think you'll see that more and more across the country. And I believe, last slide, yeah, I'll turn it back to what, Katie?
Yes, thank you. I will take it. Thank you, Tracy, for that. That was very informative and helpful. We did get a few questions in the chat while you were talking. So before we jump into the next couple of topics, we wanted to just go over those questions. So let me go back up to where that started. Okay, the first question was from Nancy Cronin, so thank you, Nancy. And she's asking, do we have any data? I think this was at the beginning of the presentation. Do we have any data about the types of clinical needs in the group homes? For example, like how many children have some kind of like autism spectrum disorder or other developmental disability? Nancy, feel free to unmute yourself and share additional thoughts if I'm missing it. But I think this was in the question regarding like there are children placed in group homes today that like, quote, shouldn't be there.
Yeah, and I would just say that the feds looked at this at the federal level. There was a study done by the Government Accountability Office in several years ago, and they found that 40% of the kids in group placements had no clinical needs. But it wasn't specific to Maine. And your numbers are so low that I suspect you do not fall in that category. I think you already have a process that allows access to group care that is much more clinically oriented, but you would know that better than I.
Yeah.
Yeah, this is Nancy. I think we need to, without a doubt, look at this when we're determining what our plan should be. I think there is I've been looking at the autism data in the state over the last 10 years, and there's been a steady increase of children with autism in the child welfare system, especially in the group home system, and that has changed over the last 3 or 4 years. It's not an enormous number, but that's only because the main care data that I had, you had to identify a kid with autism spectrum disorder, and but I did notice that almost all of them were in group home settings.
So that's, to me, I've heard that elsewhere. I think the question is that because the parents can't care for them, or I'm not going to second guess parents' needs and the kids' needs, but I know a lot of states have tried to serve that population more within family settings. I don't know if that's an option for you or not. You just have so few kids in group care that you're doing something right.
Right. All right, thank you for that. We also had a follow-up question from Mark Rains asking really more or less about like if you need to bill commercial insurance first before Title IV-E, when we talked about like the payer of last resort.
No, I mean, that's really just Medicaid. That's all that's about. They're not going to expect any billing of, that's really done through the court, whether the court basically takes a percent of the money from the parents to pay for the services. And some states do that very aggressively. Some don't. But there's no expectation you would bill commercial insurance.
Okay. And then also another question that he had was, really how do you operationalize trauma informed?
See, that's going to be up to each state. That's one of those issues where the Fed said, yes, you have to do trauma informed, but that means each state has to decide what's trauma informed to them. So I think there's plenty that's been written on trauma. I think that the key issue, and that's why they've got a lot around caseworker training, is how you take the concept of trauma informed and get that into an operational system that caseworkers or therapists or whomever can actually follow. And again, the feds are not giving you any direction on that. That's on each state to decide.
Thank you, Tracy. A couple more questions just popped up. We've got a question from Rich Hooks Wayman. If agencies or providers have the capacity to deliver evidence-based practices, but don't because the Medicaid rates are too low to make the services financially sustainable, could Family First funds be used to supplement the rates and make more services, make the services more enticing?
Yeah, that wouldn't work. I mean, Medicaid already has a rule that has to be 100% of the payment. I think you would have to somehow define the service differently and then come up with the rate that's different based on the different definition. Maybe you're defining your service population differently. I mean, that's a possibility. It gets into all this, how do you game the system in order to meet your needs? If the Medicaid rate is so low that no one will provide it, then couldn't you call it something else and narrow the definition of who you serve, and then just have a contract through the child welfare agency? Of course, that's up to the child welfare agency, but that's possible.
Yeah.
You can't bill both, though.
Yeah, and Tracy, I'll add to that. In PCG's experience, we're helping several states implement Family First. And we have seen that it depends on how the rate, the unit of payment for a service works. So in another state, they might say, I'll pay the provider, X number of dollars per family to provide prevention services, whatever that means to you. And if the state, or if the provider rather, bills Medicaid for the Medicaid allowable expenditures, but that we know the provider also does other stuff, to get that evidence-based practice, offered to the family. If those other things that aren't funded through Medicaid are Title IV allowable, then you can claim those dollars to Title IV.
But
so it's a matter of semantics.
Yeah,
right.
Exactly.
It's all how you label stuff. So
Yeah.
the answer is yes, but we would have to make some changes. Yeah. Okay, thank you. Couple more comments or questions from Lindsay. She just shared, it's surprising that the clearinghouse rated TFCBT as promising. I believe all other evaluators have rated it as well supported. Do you know what led the 4E clearinghouse to reach that conclusion?
Honestly, I don't, but that is the kind of decision that makes me think they have gone overboard with their academic requirements.
Yeah.
And I think that, I hope that the developers will submit additional data, but I think that's why my belief is that over time, there's not going to be enough services that meet the well-supported, and there's going to be a change in the standards.
Yeah, Lindsay, you are not alone in asking that question in our experience with other states. All right, and so the last question is from Mark Rains. He says, reference for the process of homegrown or within the state authorization of an evidence-based practice listed on the slides to be archived. Mark, can you unmute yourself, maybe add a little to that? All right, well, Mark, if you can't unmute yourself, reference.
Well, I could just say,
Sure.
I think that the goal was never to say a good service shouldn't be provided. If you've got a service and you've got some evaluation and it's for a particular population and you don't feel that it just doesn't have the evidence, that doesn't mean it's not a good service. Now, what it may mean is that it can't be funded initially through the Prevention Services Act or side of the funding pool. But I wouldn't want to see states just bypass services that they think are good services that are meeting a particular need. I think the goal would be to start collecting some data. If in fact 3-4 years from now the standards for evidence are loosened up a bit, then you might find yourself in a place where you have the evidence, enough evidence.
Sure.
Thank you. I'm unmuted now. I was thinking that you'd mentioned there was a process for us to collect that data or be able to submit that, and I don't need it now. If it's in the slides and we'll see those, that I can wait for that. But it sounded like there was a process that would take time, of course, but we might start at some point. The other thing is there's a whole handbook of how they do their evidence-based ratings, and I'll try to put that URL in the chat. Unless you already have it for us.
It's on the slides, the handbook.
That goes into quite a bit of detail and 8 or 9 different clearinghouses they sampled and how they came up with things. And I share concern about their process, but that's the answer to how do they do it, I think.
Right.
Yeah.
Thank you.
All right, well, thank you everybody for your questions, and thank you, Tracy, for your input. We will scooch along in our agenda. So now we're going to talk about the EBPs in Maine. And we're going to first start with this questionnaire. So Christine sent out a questionnaire to many of the folks that are on the call today a couple of weeks ago just to get some feedback from you to say, what kind of EBPs are you currently offering, within your agency. So this slide and the next couple of slides are a summary of what we heard back from you. So we sent let me let this person in from the lobby. There we go. We sent the questionnaire to about 46 folks. We got 15 responses back, and I think that was per agency. So I know there's more than one individual per agency on the work group, so that explains the 15. Anyway, so we asked which of these EBPs do you offer within your agency, and we asked about these specific mental health EBPs, substance abuse EBPs, and then in-home parent skill-based EBPs. And here's what we heard back from you all. A lot of TFCBT, we got some MST, motivational interviewing was pretty common, parents as teachers, triple P, and incredible years. And then we'll go to the next, not that way, there we go. All right, and so then we also asked, kind of in more of an open text type of a question, what other EBPs do you offer? And so here's a list of what we heard back. I won't read them all to you, but obviously there are a number of other EBPs that you're offering, and this kind of really speaks to Tracy's point before, in that you're offering many other EBPs that may as well someday be on that Title 40 Prevention Services Clearinghouse. And so we just wanted to share that with you today. And we'll give you a copy of this presentation as well. And lastly, we asked what other models or programs does your agency offer? And so this was less of an evidence-based practice and just another, program or model that you use when you treat the children and families of Maine. And here's what we heard back from folks. So a lot of opportunity out there considering EBPs and potential future EBPs as well. And then this last question, there's a lot going on in this slide, but I wanted to share this with you because we asked respondents to respond to each of these sentences saying, is this statement completely true? Is it mostly true, slightly true, or not true at all? And this was just a gauge to measure readiness or your EBP capacity. So as an example, financial resources are adequate and available to sustain EBPs or other treatments or models. Do you find that statement is completely true, mostly true, slightly true, or not at all true? So we asked that about financial resources, a diverse internal team, protocols for hiring staff and staffing decisions, adequate time for training, practice and assimilation of new skills, a documented plan for training, practice, and assimilation of new skills, demonstrate proficiency in delivering evidence-based interventions, a consultant that's available for support to staff, and lastly, time and resources for fidelity monitoring. And overall, looking at the responses that we got, it looked like about again, just an average, just a glance at the feedback that we got, respondents seemed about 74% ready for this. So we wanted to share that with you as well today. Okay, and now I'm going to turn it over to Anita Hood to tell us a bit more about the EBPs in Maine.
Thank you, Katie. Hi, everyone. I wanted to talk a little bit about some of the specific things that we are doing here in Maine on these particular evidence-based practices. So many of you probably know that there was a recent rate study conducted by Burns and Associates on FFT, MST, PSB, and TFCBT. The results of that rate study suggested an increase in those rates, and I believe the rates will be released this week with hope to implement on May 1st, which is Friday. Specific to TFCBT, OCFS is bringing in nationally certified TFCB trainers to train 3 cohorts of 60 clinicians for a total of 180 clinicians statewide. The goal is for these clinicians to be nationally certified over the course of a year. The hope is this will start in July, and there will be more information coming on this specific strategy in the next couple weeks. So definitely be on the lookout for that, and to share if you would like to participate in that training that will be coming in July. I also wanted to touch on the attachment and biobehavioral catch-up and just let everyone know that there is currently a pilot with Maine General for that particular evidence-based practice. As Tracy had mentioned, that is currently being reviewed through the Title IV EAT Clearinghouse. And also not on the slide, but I wanted to share that OCFS is exploring evidence-based practices for youth with substance use disorders as well. And so we ultimately hope that we can increase capacity of evidence-based practices across the state and also increase access to children and families. We're definitely open to other suggestions, other evidence-based practices like we've talked about, or practices where we can gather data and then put forth. And all other suggestions are definitely welcome. And with that, if there are any questions, I will turn it back over to Katie.
All right, thank you, Anita.
Thank you.
Before we move on, I'm gonna go back up here to this. We got a question from Mallory, and she asked, did that question break out as to agency readiness versus sustainability of the rate to support the service? There are concerns about the new rate being proposed for MST and FFT. And to answer your question, no, when we sent this questionnaire out, it was not in regards to rate. So thank you for sharing your thought. And this readiness is just focused on the internal capacity in terms of staffing and preparedness for training and things like that. So thank you for asking that. And then Rebecca just asked, who at OCFS is leading the training efforts, specifically organizing the training efforts for TFCBT? So Anita, can you speak to that?
I certainly can. Amy Beaulieu and I are leading the TFCBT training.
Thank you. All right, so now we are going to shift gears into our last portion of the agenda where we're going to talk more of a Q&A. And so this is where it gets fun when we're on Microsoft Teams rather than being in person. So I'm going to ask a question, and if you could, folks, just unmute yourselves if you'd like to speak, and we'll do our best to manage it amongst the crowd. But we really do want to hear back from you when we ask these questions. So the first question being, thinking about the families that you're currently serving, what are the common risk factor themes that you see?
I would say generational trauma would be a huge theme.
Thank you. Yeah.
Certainly maternal depression, substance use, and poverty.
Mm-hmm.
Hi, this is Jenny Gates from Maine. I would say we serve a lot of families in rural areas where there's limited services available.
Thank you. Mm-hmm.
I just echo substance use disorders, generational.
Sure. Yeah.
And this is Nancy Cronin again. I would say that there has been a large number of families that have indicated that they feel like they need to give up their families, their children, because they either cannot take care of them because of challenging behaviors, or that they fear that they won't be able to get there's this feeling that they won't be able to get services for their children, and other people, if they were in the foster care system, would be able to.
Okay.
And these are kids with developmental disabilities. I think that having learning disabilities or developmental disabilities or that kind of challenge like ADHD as well as autism, et cetera, is also a risk.
Yeah.
This is Jim Jacobs here. We see parents that have the substance abuse issues, but I'd like to point out that they're often opioid and they're picked up at childbirth or during pregnancy. So they're very young children that get removed. And then we also see parents who have themselves developmental disabilities that aren't able to access or utilize services. And lastly, we see parents who have mental health issues themselves that are poorly managed and their kids come into care.
Thank you for sharing that. Okay. And Christine and Anita, feel free to weigh in if you have follow-up questions. But thank you, folks, for your response on this one. Any other thoughts on this before we move on to the next one? All right. All right, so the next question is, what are some family needs that could be alleviated with in-home supports and services?
Hi, this is Jenny from Wings again. This kind of made me think of another barrier. Adequate childcare for children with special needs, I think, is a barrier, and also something that could be alleviated with in-home school.
Absolutely.
Oh, this is Jim Jacobs again, and just to maybe put two things together that one of the other participants said, kids with very strong mental health or behavioral issues. And then when you mix that with parents who have their own limitations and then the services aren't available in homes, then it's not a good mix in terms of potential dangers to the kids. So in-home services for them, if they could be increased, that with the caveat that some of those parents, the ones that need those services the most, are sometimes the ones that often fight against it and feel that they're being picked on or them selected out somehow. So that would have to be overcome.
Yeah, and this is Nancy Cronin again. I wanted to put the two things together as well and say many individuals who have substance affected disorders or families that have substance abuse issues, the children are at higher risk of maybe having a fetal alcohol spectrum disorder, and that might not be recognized, assessed, or even it might not even be possible to figure out. However, that also can lead to challenging behaviors, and developmental disabilities. And life skills in-home support services could teach different ways of handling or dealing or communicating. And that is a big thing that in-home supports can do. So depending on the level of dysfunction of the child, it might need to be literally giving people communication ability, giving people ways to communicate as opposed to processing it, less of a mental health, more of a, this is the way you can communicate these feelings and knowledge about it.
Absolutely. Thank you for that.
This is
Karen. Sorry, just real quick. I think some education around what trauma response looks like for kids could be really helpful to parents in understanding behaviors.
Education about what trauma response looks like?
Yeah, about the impact of trauma and what the response might look like and how it might be communicated through behavior.
Thank you.
This is Carrie from Maine Parent. For those kiddos whose behaviors are a manifestation of their disability, proper in-home support services can alleviate the need for higher future out-of-home placements. A lot of kids who may end up in crisis, I think, may not end up there if they had the proper in-home supports prior to. So while there is a need for PTRFs here in the state, I also think there's a need for proper in-home supports, and money should be placed there so that we're not referring so many kids to those type of facilities.
Thank you.
Yeah.
Jim, did you have another thought?
Yeah, this is Jim Jacobs. Just an interesting thought, because we're, as Maine General, we're doing that ABC kind of prototype. And one of the things I've talked to our providers, so I think one of whom is at least on the phone call today, is that there's a reticence for people who have these sometimes serious problems to have people come into their homes, but there's some evidence now because of the COVID-19 sheltering, is that ABC is trying telehealth and researching that. So telehealth itself may be a way to get into some of these homes that have previously been kind of resistant to having people come into their homes and provide support. So there are actually new technologies and new methods that are developing even now that haven't been tested for evidence base because they haven't been tried yet. So there may be these issues also.
Absolutely. All right, thank you for that, everybody. All right, we've got another question here. What suggestions do you have for new and enhanced services? And we've touched on this a little bit, I think, through the chat, but I'm curious to hear your thoughts on that.
So this is Christine. I'll just add, I think that this is where it's really important for us. I mean, I think we need to look at some of our data, on the families that we're serving with OCFS, but also thinking about, there's a few people who mentioned services that, like the nurturing parenting program. I think there was actually probably 4 or 5 people who responded to the survey that they're implementing that. And I'm interested in hearing more about who's doing that, because I think that is one of the services that was being reviewed by the clearinghouse. And it's something that's come up in a couple of other meetings. But, I think this is where it's really important for us to hear from you guys of like, what are you seeing within the families, what's working, what's not working, and do you have suggestions for programs that we should consider implementing in Maine? Again, I do want to hear from those people who may be implementing nurturing parenting.
So this is Carrie from Maine Parent. I would just, I would say to make sure, I don't know about a specific new service, but I would make sure that we have the right services in place to meet the individual needs of the disability or diagnosis that the child may be struggling with. We've seen the rollout of behavioral health homes here in Maine. And I don't know that, I'm not saying that that's a bad thing, but I've seen behavioral health homes applied to individuals with developmental disabilities, and it's not necessarily the right match. So mental health strategies for a child with an intellectual developmental disability and an in-home support service isn't necessarily the right match in providing that child with access to the services that they need. So I would encourage services that make sure we're providing the right services to the child to meet their needs and not just to take them off of a list because they've been waiting for a long period of time.
This is Carla Stockdale with KBH. I know that we have FFT and MST in the state, and we actually provide MST at KBH. I saw that I know the child abuse, I believe, and neglect module of MST does not meet any of the thresholds for standards, but was wondering if FFT-CW had been considered at all, because both FFT and MST obviously focuses more on keeping kids more in the juvenile justice end of things, although it does address multiple issues, but it's specifically targeted to a population where those child welfare models could really cover a younger group of kids as well. So that's just a question.
Sure, yeah.
Could I add that I was sort of surprised at that myself, and I know that FFT for child abuse is being tested or has been tested in Delaware. So I was sort of surprised it was not on the list, but maybe it'll be next time.
And
I was just thinking where we already have those. Sorry.
No, go ahead.
I was just thinking where we already have those built, so to speak. I know we need more to sustain them, but those would be kind of a natural place to kind of continue to build where there's some infrastructure already.
Right. And Tracy
This is
mentioned
Mark.
a good point earlier. There are other states out in the country that have approved state prevention plans. And in some of those state prevention plans, they have submitted an independent systematic review for a program that you do not see on the Title IV clearinghouse. So in the interim period of time before the Title IV clearinghouses had an opportunity to do a full and complete review on those programs, they're actually reimbursable by Title IV. For example, the state of Kentucky has included the START program in their prevention plan. That was just approved 3 weeks ago. And so that's technically claimable to Title IV to other states at this point in time as well. So good point, and I think it'd be worth doing some digging on the FFT for child welfare. So sorry, I didn't mean to cut somebody else off. Go ahead.
This is Mark Reams. I think that Circle Security Parenting is one of the interventions on their list to be reviewed, and that might be a prevention-focused practice that would focus on attachment and stress trauma issues as well. So that might be on a list to explore. I'd be glad to join others in that.
Sure.
This is Bonnie from up in the Bangor area. We do use nurturing parenting in our HCT program as one of the curriculums that we use in our parenting. We have had grants in the past to do it through groups, but in rural Maine, it's very difficult to get a cohort of parents that are ready and willing at the same time to get a group together. So one of the things that we toy around with is like, how do we get these evidence-based practices out to the rural areas? And I think if we looked for a grant again, it would be to maybe try to do it through telehealth and Zoom groups. Or whatever, and of course, like right now in the midst of how most of us are practicing now with telehealth is like, how do we take, I have staff trained in child parent psychotherapy and TFCBT, and so I think one of the things that we probably need to think about is like how to use technology with some of these services. So I just kind of want to throw that out there.
Thank you. That's a good point.
Hi, I'm not sure how the unmute works. I guess I am unmuted. Hi, Katie. My name's Lindsay. I'm actually, my name confuses a lot of folks. I've actually fully transitioned. So far, I've actually overshot the mark. I'm into male pattern baldness now. But anyway, what I wanted to ask about is obviously a lot of the CPS child protection involved families have multi-generational, mental health and trauma and SUD problems. And it was already mentioned, I think, by Tracy that often the child welfare caseworkers can have a hard time coordinating with, for instance, the adult SUD providers. Mm-hmm. And also, we in the children's mental health world can have a hard time coordinating with the parents. Mental health SUD providers. A long time ago, I used to work for a program in Portland, Children's Act. It was called the Anchor Program, and we used to we of course treated kids, but we also did the mental health treatment for adults. We would, because a lot of the adults had a lot of untreated mental health problems, and actually Suboxone was just coming online then, and we actually were getting ready to do Suboxone also when there was a quite substantial rate cut during the Great Recession. But anyway, so this is kind of a vague suggestion and question, but if there's any way to incentivize or facilitate a so-called two-generational approach, one team or one agency with different parts of a team, working together with the family. I just want to put that out there that could be quite helpful and effective.
Thank you.
Hi, this is Rebecca Hoffman-Francis, and I will also add to what Lindsay's saying, just in general, in terms of the two-gen approaches, looking at interventions that really focus on that, in particular in early childhood, which are obviously the best in terms of intervention plus prevention. And I was interested in child parent psychotherapy. I missed the very beginning, so maybe you talked about that, but I was surprised not to see that anywhere mentioned.
Thank you for sharing that. That's helpful. All right, I think we've got one last question, and we've touched on this, I think, a little bit as we've answered the other questions, but we wanted to throw this out to the group. You know, what are the barriers to implementation of evidence-based services with families? Looking at the feedback that we got from the questionnaire, cost seemed to be one, perhaps, a consideration of a barrier. Or we mentioned folks out in rural Maine, like getting services to those folks out there. Are there any topics you think we haven't touched on that you would consider a barrier to providing an EBP?
This is Rebecca. One thing I would add, beyond cost, so cost of training and cost of maintaining skills, would also be fidelity monitoring. So
yeah,
we don't have a really robust way to do that, as well as outcomes measurement. Both of those are so important to actually reducing treatment drift. And so just, I think for mental health organizations to kind of figure that all out themselves, as well as actually finding the money to train their clinicians and take them offline, is kind of it's been a really heavy lift for organizations to do that.
Sure.
And I would add retention of those trained staff would be like the second challenge.
This is Nancy Cronin. I'm not sure whether or not this fits here, but I don't want to lose it. Very often, foster families receive children with disabilities in their homes. Especially, for example, we recently got a call from a family whose foster child has ADHD, and they didn't have any knowledge about evidence-based practices or ways of being able to support the child with this disability in their home. So one of the things that I think is really important when we're looking at this is how will we support people being successful in foster care practices, as well as moving back home or preventing from moving out in the first place. But there needs to be some carryover in foster care placements. I wonder whether or not one reason kids get into more restrictive group home settings is because it wasn't successful due to behavior issues in a foster care setting or the family. So when we're talking about these training, it has to be in foster care families as well, because there you go.
Right. Thank you for that.
I will add that a lot of the prevention services funding is available for children living with kin. So you could, in fact, train your kinship families. It's not considered prevention if the child's already in foster care, so that won't work. But you might think about those kin families.
This is Jim Jacobs, and I think one of the issues that you have to consider, I'm kind of a scientist by training, is that one of the barriers to providing evidence-based programs is evidence-based programs. And by that, I mean, I was just out at the Child Welfare Conference in San Diego and listened to some people talk about their evidence-based programs like Colorado and the Kemp Center, which is well known. And they had an evidence-based program that they were using for prevention. But when they ran the stats on it after 5 years, it didn't reach any significance about keeping children from coming into the child welfare system. One. The other part of that is because it's an evidence-based system, you have to follow a man. You have to kind of do the steps to get the evidence. And when they asked parents about the evidence, they had a high kind of dropout rate of people who would probably be more at risk for child welfare issues. And they said that the way it was taught, there was a first module on safety, how to cover up the sockets in the house and make the place childproof. And the second module, which they never got to, was on parent-child relationships. And when they found out about that, they said, well, they would have stayed in the program if they had that part first. But they couldn't switch the modules because then it wouldn't be evidence-based anymore. So my thought is, if evidence-based program isn't working, we have to look at switching it in process and not just continue to kind of destructively barrel ahead and not make it fit Maine kids and Maine families. So that's my worry, I think.
And I agree. I think that's why they want to have all this evaluation data ongoing, so that they can see, well, if this doesn't work for this population, then it doesn't matter what the evidence is. It doesn't work for the child welfare population.
Right.
But obviously that the fidelity issues and all of that are so integral to how something is implemented in terms of what the outcome is. The other thing is that there's an awful lot of evidence-based programs that may in fact not thinking that the bottom line is preventing placement. It's around some skills and some relationships, but connecting the service model to the idea of we want stability in this family, and we want this family to be able to stay together, is not always clear. And I think if you don't have that focus, then you sometimes don't get that outcome.
Thank you, Tracy.
I wanted to ask Tracy a question, and Tracy, I apologize. If I had been paying more attention, I probably would have seen this in your earlier presentation. But okay, so once a child has been removed and is in a foster home, and let's say it's a child with significant behavioral health needs, they're in a treatment foster care home with a treatment foster care provider.
Mm-hmm.
Can these programs, which are no longer, of course, preventing placement, but they might well be preventing residential treatment, can a program like PCIT, for instance, be used in that? Can Family First funds be used to support that, helping the child stabilize at that level?
Yeah, you can't. Once the child's in custody, the access to Family First is. Wait a minute. Was I on? No.
Sorry, there's a little bit of an echo.
Once the child is in custody, you cannot use those funds any longer.
Okay.
And even if a child is stepping down from residential to foster, they're still in custody. So
right.
You can't use those funds. Now, in theory, you should be able to put Medicaid services into a foster family.
Right.
So that would work. You could do it if the child went to kin on a permanent basis, but you can't do it in a foster family.
Okay. Right. Well, the fact that, of course, Alyssa and her team is here, and that Dean from Maine Care was on the call too, is presumably reflective that all the parts of DHHS are trying to closely coordinate. So hopefully, for that youth at a treatment foster care home, something like PCIT would be available through Maine Care.
I would add that, and I don't know how this works in Maine, but one of the excuses for residential care has always been, and this is nationally, this is not specific to Maine, is always that we put kids in residential after they fail out of foster care. And in fact, the evidence does not prove that out, that a high proportion of kids go into residential as their first placement. So in fact, Congress isn't buying that, these kids are failing up quite as much as people have portrayed it that way. And as I said, I don't know if that is the case in Maine, but it is certainly the case in a lot of states.
Thank you. We've gotten a couple of other barriers to implementation in the chat. I just wanted to share with folks. Thank you, Deb, for saying one of the other barriers is engagement with parents. We should include training on parent trauma responses for providers in the plan for trauma-focused care. as trauma responses in adult caregivers are often one of the barriers to developing effective therapeutic alliance. And Mallory also shared and had a question, travel time not being billable and the rate not covering that is a huge barrier to the rural areas of the state. Could Family First funding be used for this? Well, Tracy, do you have a thought on that one?
Well, transportation is not really a service, but you could certainly build transportation costs into the service cost.
Right.
So it's not an independent service, but you could build the cost of transportation into the cost of any unit of service.
Right. It's a cost that you incur to provide that evidence-based practice to that family. So I agree with Tracy. You wouldn't, like, that in and of itself is not billable, but like it is a cost to provide that service, so it could be included in the rate. And lastly, Amy has asked, what states have approved FFPSA plans? Tracy, you want to speak to that?
What I won't remember them all. Arkansas, Washington, D.C. I think Utah may have theirs, and Kentucky.
Yeah.
That's all I'm thinking of right now.
Yeah, there's just a handful right now. Amy.
Not very many. DC's was the first, but everybody's sort of trying to figure out what they're going to submit, and then there is some negotiation before it's approved. And I keep checking the federal website and hoping that they put the plans on the federal website, but I haven't seen that yet. So it would be helpful.
So we, this is Christine. I would just add that, so I'm very lucky that I do have, in other states, we have access to a biweekly learning collaborative with other states, and we also have access to a learning collaborative portal that has other state plans. So I can assure you that I've been digging and reviewing and determining, like other states, what are other states doing with all of these different components of Family First. So we are very fortunate that other states who have had approved plans, we can learn from them as well. So we can try to bring some of that maybe to our next stakeholder work group. We can bring forward some more information about some of the evidence-based practices that have been selected.
Thanks, Christine. All right, well, that brings us to the end of the questions that we had prepared. I'll give folks an opportunity. If you have questions or comments you'd like to share now, please feel free to do so.
I just
Open
wanted.
Go ahead.
I just wanted to give a quick shout out to Jim Boer and Dan Despart. Tracy had mentioned that Maine ranks fairly high in the nation in terms of having a low use of residential treatment for child welfare kids. Jim Boer was a very controversial guy when he was here as head of OCFS, but during his time, I think, total residential treatment went from 850 to 325 or something like that. And a lot of that was kids in custody. So anyway.
Mara was the instigator of that.
Say it again, Tracy.
I think Logan Mara was part of the reason why the reforms were.
Well, right. So I guess we should so we should pay homage, if you will, or respects to Logan Mara.
Thank you. Thank you. And Amy agrees with you as well. All right, any other thoughts or comments? All right, we've got one question in the chat. Are the eventual reimbursement rates for these services established by the states, or are they already determined by the Family First Act?
No rates are in the Act. It's all state.
Yeah.
There's too much variation in the costs across states.
Right. All right, so I think, Christine, I'll turn it back over to you.
Yeah, so I just want to thank everybody again for the great conversation and for the engagement. This is, I think all of our 4 stakeholder groups have kind of followed this format with a introduction and overview of the Act. And so I think, what we're doing is initially taking some of the feedback we're getting from these work groups and then going back and meeting internally and kind of sorting through the information. There is some overlap with this group as well as the workforce group that we had late last week in the candidacy discussions and all of that. And so we're trying to pull together some information internally to then bring back to our stakeholder group, because some of these groups, as well, this one was we had over 50 participants, which is wonderful, but it's also hard. And especially in the current COVID situation that we're in, we can't meet around a table and actually have individual discussions about some of this stuff. So, I think we're going to do similar as we've done with the other groups, and that we're going to pull together the questions and answers and the notes, recordings. We have our Family First website, web page on the OCFS website that's going to house a lot of documents and information. We have we've just updated it, and so there, we're going to put some information there. I'm going to email you guys out with some of these, the more information, and as we pull together some internal discussions, we're meeting with Maine Care internally. Like, we have some things that are happening. So even if this group is not meeting every other week, just know that the work is moving forward. And my intentions is to bring things back to this work group to get additional feedback and thoughts and suggestions and ideas. But if you have anything in between the time that we meet, I welcome you to email me and give me additional thoughts and suggestions. And it's welcome. I mean, we're in this together. This is a team approach, and we're not going to build this state plan in a silo. So, so I think that's all that I had to say for that, and we'll be back in touch with everyone through email to give you again some of the resources from today. And again, I appreciate all of you guys' engagement and participation in this, and the other work groups as well. I know there's some overlap, so thank you.
All right. Thank you, everyone. Have a great day.
Bye.
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 Thank you.